If you were to walk into the first obstetrical clinic at the Vienna General Hospital back in 1847 to deliver a baby, it was basically a death sentence.
Yeah, pretty much. I mean, it's hard to even wrap your head around today.
Right, because the mortality rate from puerperal fever, which is this severe uterine infection, was hovering right around 18%. So almost 1 in 5 women just didn't survive.
That's just a staggering number.
It is, but the most terrifying part for you, if you were a patient or even just an observer back then, wouldn't just be that death toll. It would be realizing that the killers responsible for this were actually the doctors themselves.
Yeah, and the crazy part is those doctors were completely oblivious to it. I mean, they had no idea.
Right, which perfectly sets up our mission for this deep dive. Today we are looking at the pathophysiology of wound infection.
Exactly. We're going to explore exactly how an infection hijacks the body's healing process, why defining an infection is actually surprisingly difficult, and just why this invisible battle is one of the biggest problems in modern medicine.
And to really understand how an infection derails healing, we kind of have to start at the dawn of this whole invisible war. Back in a time when doctors didn't even know infection existed.
Right, because in the mid-19th century, the medical establishment absolutely did not believe in microscopic pathogens.
At all.
Not at all. If a wound became infected and a patient died, the smartest doctors in the room blamed it on miasma, which they basically just thought was bad air. Or they'd blame an internal imbalance of the body's humors.
Because the very idea that a doctor could be carrying a tiny, invisible killer on their own hands it was practically offensive to them.
Oh, highly offensive. Which makes the story of Ignaz Semmelweis just so fascinating. He was this Hungarian obstetrician working in that exact Vienna hospital you mentioned.
The one with the 18% mortality rate.
Right. And he starts looking at the data. And he notices this massive, glaring discrepancy. So the hospital actually had 2 maternity wards. The first ward, run by the male doctors and medical students, had that horrific 18% death rate. But the second ward, which was run entirely by female midwives, their mortality rate was only about 2%.
Which is a crazy difference. I mean, they're in the same hospital.
Exactly. So he looks into it and realizes the only major difference in their daily routines is that the doctors and the students were routinely performing autopsies on cadavers in the morning.
Oh, geez.
Yeah, right before heading up to deliver babies.
So they were going straight from the morgue to the delivery room.
With no hand washing. So Semmelweis makes this brilliant deduction. He theorizes that the doctors were carrying these, he called them cadaverous particles.
Cadaverous particles.
Right, he didn't know what they were exactly, but he figured they were carrying them from the morgue straight into the open wounds of these mothers. So he implements this strict new policy where any doctor leaving the autopsy room had to scrub their hands with a chlorinated lime solution.
Just a basic chemical scrub.
Yeah, before they could even examine a pregnant woman.
And the results were they were immediate, right? The mortality rate in the doctor's ward plummeted from 18% down to under 2% in just a matter of months.
Which is incredible. He essentially figured out contact transmission just by watching the data.
But because he didn't have the germ theory to back him up, he couldn't explain the actual mechanism, the medical establishment just completely rejected him.
They mocked him. They eventually had him committed to an asylum.
Which is just so sad. And then in this brutal twist of irony, he actually died in that asylum from a gangrenous wound infection.
Yeah, the man who essentially discovered how to stop wound infections was killed by one. It's really a tragic origin story. It took a couple more decades before Louis Pasteur proved that living microorganisms actually cause putrefaction.
Right, he provided the actual theory.
Exactly. And then in the 1860s, you have a British surgeon named Joseph Lister who finally applies that theory to surgery.
And quick fun fact from the sources here, Listerine-like, the mouthwash we use today, was actually named after him. It was originally sold as a surgical antiseptic.
Oh, really? I didn't actually know that. That makes total sense, though, because Lister started using carbolic acid, or phenol, to chemically sterilize his instruments, the dressings, and the wounds themselves.
And it worked. He published this landmark paper in The Lancet in 1867 showing that mortality from compound fractures dropped from 45% to roughly 15%.
And a compound fracture back then, where the bone physically breaks through the skin, that was classically a death sentence from infection.
So Lister proves that survival isn't just about how fast a surgeon can chop off a limb, it's entirely dependent on controlling these microbes.
But even with all of Lister's data, shifting the mindset of surgeons was a massive uphill battle. because they were conditioned to look for very specific, dramatic, visible signs of healing.
Because they're fighting an invisible enemy, so they need something they can actually see.
Exactly. And that reliance on visual markers led to one of the most misguided, bizarre concepts in medical history, which is the idea of laudable pus.
Yes. I cannot get over this detail in the sources. So laudable literally means praiseworthy, right?
Right.
So for centuries, a surgeon would look at a wound that's just oozing this thick, creamy, opaque pus, and they would literally celebrate. They thought it was this great natural sign of healing.
They were cheering for it.
But chemically, mechanically, pus is just a graveyard, isn't it? It's just a massive pile of dead white blood cells, tissue debris, and millions of bacteria. It's like seeing smoke pouring out of your car's engine and thinking, great, the engine is finally warming up.
That is exactly what it's like. They were essentially cheering for the destruction of their patient's own tissue. By relying on these massive visual cues, they completely missed all the quiet, microscopic ways that bacteria stall the healing process long before you ever see pus.
So, okay, if I'm looking at a cut on my hand right now and I know invisible bacteria are everywhere, my logical assumption is that if a single bacterium gets into my cut, I have an infection. But the modern medical definition isn't nearly that simple, is it?
No, not at all. If bacteria being present equaled an infection, humanity would be wiped out. Every single open wound is contaminated because we don't live in a sterile vacuum.
Right.
So the International Wound Infection Institute actually formalizes this into a spectrum. The very first stage on that spectrum is simply contamination.
Meaning the bacteria are just there.
Exactly. They're on the surface, but they aren't multiplying, and your immune system isn't reacting to them.
So they're basically just tourists at that point.
That's a great way to put it. Just passing through. The next stage up is colonization. Here, the bacteria find the wound pretty hospitable, it's warm, it's moist, so they start to multiply.
Okay, that sounds bad.
It sounds bad.
Yeah.
But they are still just living on the surface. They aren't invading deep tissue, they aren't delaying healing, and honestly, this stage is unavoidable in any open wound.
So if contamination and colonization are totally normal, there has to be a tipping point where the body's defenses finally get overwhelmed.
And that tipping point is stage 3. Local infection. Some of the literature calls it critical colonization. This is when the bacterial burden crosses a threshold and they begin to subtly derail the healing process.
But they don't necessarily trigger those massive dramatic alarms yet.
Right. They're doing damage, but it's stealthy. If the body can't contain it there, it moves to stage 4, spreading infection. That's when it invades surrounding healthy tissue.
Like when you see cellulitis that's spreading redness.
Exactly. And then the final stage is systemic infection. That's when the bacteria or their toxins breach the local area and enter the bloodstream. That triggers sepsis and systemic shock.
So I want to focus on that tipping point, the local infection stage, because you said it doesn't always trigger massive alarms, but our sources bring up the Roman encyclopaedia Celsus.
Right, from nearly 2,000 years ago.
Yeah. He gave us those classic 4 signs of inflammation: rubor, calor, tumor, and dolor. So redness, heat, swelling, and pain. Plus, Galen added loss of function later.
Like classical signs.
Yeah. So if I get a deep splinter and it gets red, hot, swollen, and hurts like crazy, I know it's infected. If those signs have worked for 2,000 years, why did they fail us in modern medicine?
Well, they don't fail healthy people with acute wounds. Like with your splinter, if your immune system is robust, it mounts a massive response, which creates all that heat and swelling.
Right. My body is fighting back.
Exactly. But those classic signs fail completely when we look at modern chronic wounds. Think about a diabetic foot ulcer or a surgical wound in someone on chemotherapy.
Because their immune systems are suppressed, they literally can't mount the biological response needed to make the wound turn red and swell up.
Precisely. Which means a local limb-threatening infection can look deceptively quiet. It might not look infected at all to the naked eye. So in the late 90s and 2000s, specialists like Keith Harding and R. Gary Sibold realized they were missing these stealthy infections.
So they had to come up with new diagnostic criteria.
Right, they developed these new mnemonics to catch the subtle secondary signs of bacterial sabotage, like NERDs and stonies.
Okay, instead of just listing off those acronyms, let's actually look at the mechanics behind a couple of them. So in the NERDES mnemonic for local infection, the R stands for red friable tissue. Why does the tissue become friable, meaning it bleeds super easily if you barely touch it?
It's all about the structural integrity of the wound bed. During normal healing, your body builds this really delicate matrix of new blood vessels. But when a wound is locally infected, the bacteria release enzymes that actively destroy that surrounding support structure.
So the scaffolding is just gone.
Exactly. Without that support, those new capillaries become incredibly fragile. The absolute slightest pressure, even just changing a bandage, causes them to rupture and bleed.
Oh, wow. And the IPA in NERDA stands for exudative, meaning the wound is suddenly weeping a whole lot more fluid. What are the bugs doing to cause that?
Well, a couple of things. The bacteria themselves create an osmotic pull, which literally draws fluid right out of the tissue. Plus, even a blunted immune response involves some localized vasodilation.
The widening of the blood vessels.
Right, to let white blood cells into the area. But that widening makes the vessels leaky, so blood plasma seeps out into the wound bed. So if you see a sudden, dramatic increase in fluid, that is a massive red flag, even without the classic Roman signs of heat or swelling.
Okay, so to really understand how bacteria sabotage this, we need to look under the microscope at the biochemical warfare happening. Let's outline the normal construction site first. The body normally goes through 4 synchronized phases, right?
Yep, 4 phases.
First is Malsas hemostasis, where it clots the bleeding in minutes. Then inflammation, which lasts a few days while the cleanup crew arrives. Then proliferation, lasting a few weeks, where new collagen and blood vessels are built. And finally remodeling, where the new skin strengthens over several months.
That's the ideal, healthy sequence, yeah.
So if bacteria are successfully derailing this, they must be attacking the builders during the proliferation phase, right?
Yeah, actually, it's much more insidious than that. They don't just attack the builders. They completely trap the wound in phase 2, the inflammatory phase.
They lock it there.
They lock the body in a perpetual state of cleanup.
How do they even manage that?
First, they're incredibly greedy consumers. They multiply and eat up all the local oxygen and nutrients that the cellular builders, the fibroblasts, desperately need to make collagen. But the real devastation actually comes from the host's own immune system.
Wait, our own immune system?
Yeah. Your body detects the bacteria, so it continuously floods the area with neutrophils, which are white blood cells designed to kill microbes.
The cleanup crew, but in a chronic infection, they just never stop pouring in.
Right, and they bring some extremely heavy biochemical weapons with them. Neutrophils use 2 main weapons. The first are reactive oxygen species, or ROS. You can basically think of ROS as the body's own localized chemical bleach.
Bleach.
Yeah, they're these highly volatile molecules that just shred bacterial cell walls on contact.
But if they act like bleach, they aren't going to distinguish between a bacterial cell wall and my own healthy tissue, are they?
No, they absolutely cause massive collateral damage.
Yeah.
And the second weapon is even worse. Neutrophils deploy these enzymes called matrix metalloproteinases, or MMPs.
MMPs?
Now, in a healthy wound, a small amount of MMPs is a good thing. They act like precision molecular scissors. They snip away dead tissue, so the area is clean for the builders.
But if the bacteria lock the wound in the inflammatory phase, those neutrophils are just going to keep pumping out MMPs endlessly.
Endlessly. The levels become astronomical. So those precision scissors basically turn into a wood chipper. The concentrations get so high that the exact moment a fibroblast lays down a fresh piece of collagen scaffolding, the MMPs immediately digest it.
That is entirely friendly fire. The immune system is essentially dropping bombs on its own territory. It's re-injuring the wound over and over, trying to save it.
It really is the ultimate biological tragedy.
Well,
the host's excessive chronic inflammation is doing as much, if not more, damage than the bacteria themselves.
okay, but if the immune system is carpet bombing the wound with chemical bleach and these destructive enzymes, how on earth are the bacteria surviving all of that? They have to have some kind of armor.
They do, and it is honestly the single most important concept in modern wound microbiology: biofilms.
Biofilm.
The sources cite this landmark 2008 study by Garth James. He took tissue biopsies from various wounds and put them under electron microscopes. He found these biofilm structures in roughly 60% of chronic, non-healing wounds.
60%. Compared to what for normal wounds?
Only about 6% of acute wounds.
So the vast majority of these stalled wounds are harboring biofilms. What exactly is a biofilm? How does it physically protect them?
Well, when bacteria decide to colonize a wound permanently, they stop floating around on their own. They attach to the wound bed, and they start secreting this incredibly thick, slimy, sugary substance called the polysaccharide matrix.
So they build a shared bunker.
Essentially, yes. They encase their whole community in this microscopic, impenetrable fortress.
And this sticky, sugary glue just physically repels the chemical attacks.
It acts as both a physical and chemical shield. The matrix can actually neutralize those reactive oxygen species before they even reach the bacteria inside. But the scariest part is how biofilms interact with our medical treatments. That matrix makes the bacteria inside anywhere from 10 to 1,000 times more resistant to traditional antibiotics.
1,000 times. I want to make sure I understand the physics of that. Are the antibiotics just physically bouncing off the outside of the bunker? It's like trying to put out a fire inside a concrete bunker by spraying a fire hose at the outside walls?
The physical barrier is definitely part of it. A lot of large antibiotic molecules just can't diffuse through that dense, sticky matrix. But the more insidious mechanism is what happens to the bacteria deep down inside the bunker.
What happens to them?
Because nutrients and oxygen really struggle to penetrate the biofilm, the bacteria in the deepest layers shift into this low metabolism hibernation state.
They just go to sleep. But why does that protect them from the antibiotics that actually do manage to get inside?
Because of how antibiotics are designed to work. Most of them target actively dividing cells, like penicillin. It works by interrupting the process of a bacterium building a new cell wall.
Oh, so if the bacterium is hibernating, it has no intention of building a new wall anyway.
Exactly. The antibiotic is completely useless. It just washes right over the dormant bacteria without hurting them at all.
So wait, if antibiotics either physically bounce off this shield or completely ignore the sleeping bacteria inside, the logical question is, why are doctors still prescribing so many systemic oral antibiotics for chronic wounds? Aren't we just creating a bigger problem?
Yes. And this touches on one of the most intense debates in clinical practice today regarding antimicrobial stewardship. Because these local biofilm infections don't show those classical signs we talked about, clinicians are terrified of missing a spreading infection. So they prescribe oral antibiotics just in case.
But treating a localized biofilm with an oral pill is largely completely ineffective.
And it causes massive collateral damage globally. It directly fuels the rise of superbugs like MRSA.
Right, because by flooding the patient's whole system with antibiotics, you're just killing off all the weak, susceptible bugs in their body, leaving behind only the mutated ones that have evolved resistance.
Exactly. So the clinical consensus is shifting heavily toward treating biofilms as a physical problem that requires a physical solution.
You can't just poison a concrete bunker. You have to physically tear it down.
And the medical term for that is debridement. A clinician will use a scalpel, a curette, or other specialized tools to physically scrape away the dead tissue and scrape that biofilm right off the wound bed.
You literally pull down the walls.
You mechanically disrupt the fortress, and then once they're exposed, you can apply topical antimicrobials directly to the bacteria. You save the oral pills for when the infection has actually breached the local area and is spreading.
That makes so much perfect sense. But let's rewind just one step. Before a doctor decides to debride a wound or prescribe anything, they usually want to test it to see what specific enemy they're fighting, right?
Right.
If these biofilms are hiding deep in the wound bed, how do we accurately test for them?
This is another massive point of tension. The swab versus the biopsy. The cheap, fast, and totally painless way to culture a wound is just to rub a sterile cotton swab over the surface.
But based on that spectrum of infection we talked about, every wound has surface colonization. If you just swab the surface, aren't you just picking up those harmless tourists?
Very often, yes. Swabs are notorious for picking up surface colonizers that aren't doing any real damage, which gives the clinician a false alarm and leads to, you guessed it, unnecessary antibiotics.
So what's the alternative?
The gold standard is a deep tissue biopsy. The physician literally punches out a small piece of the wound tissue and sends that whole chunk to the lab.
Because that actually catches the bacteria that have invaded the deeper structure.
Right. But a biopsy requires specialized skill, it takes days to get results, and it is painful for the patient. So doctors are constantly having to weigh the inaccuracy of the swab against the invasiveness of the biopsy.
And when they do get those lab results back, there is this historical threshold I really want to talk about. The sources call it the 10 to the 5th myth or the 100,000 rule. Did medicine actually try to create a mathematical formula for infection?
Oh, they did. In the 1960s, researchers Robson and Heggers proposed this very rigid, clean rule. A wound was officially infected if, and only if, the culture showed greater than 100,000, which is 10 to the 5th bacteria per gram of tissue.
I mean, it sounds so definitive. It's an easy metric to teach medical students.
It was absolute dogma in surgery for decades, but modern microbiology has proven it to be deeply flawed because it treats all bacteria as if they're equally dangerous.
Which they aren't.
Not at all. The threshold for infection depends entirely on the specific organism's virulence factors, which are basically the unique biological weapons that particular bug possesses.
So having 100,000 of a really weak bug might be totally fine, but what about a strong one?
Right. Take beta-hemolytic streptococcus, for example.
Yeah.
It has virulence factors that aggressively break down red blood cells, and it spreads rapidly through tissue. It is deadly. For that specific bug, there is no safe 100,000 threshold. Even a tiny detectable amount is a full-blown crisis.
Wow.
Meanwhile, a patient could have 200,000 counts of some low-virulent surface bug, and the wound will heal perfectly. Treating a strict number instead of the specific organism leads to terrible clinical decisions.
It's wild. Armed with all this knowledge, like the spectrum of colonization, the friendly fire, the biofilms, the nuance of testing, it really just shatters the basic first aid logic most of us grew up with.
Oh, completely. The misconceptions surrounding wound care are so deeply ingrained, even among a lot of healthcare professionals.
Let's actually apply this new logic to a few of those common myths. Like, say I have a bandage on my leg, and when I peel it off, the wound smells absolutely awful. My immediate thought is, foul odor equals severe infection. I need antibiotics right now.
Well, odor is definitely a clinical clue. It's the S in those nerds and stonies mnemonics. But a bad smell alone does not guarantee a destructive infection. Very often, the smell is just produced by anaerobic bacteria.
Meaning bugs that thrive without oxygen?
Right. They live deep in the crevices or trapped under airtight dressings. And when they metabolize nutrients, they produce these highly odorous sulfur byproducts. They might just be hanging out on the surface harmlessly, but because they're trapped under your bandage, the smell just builds up.
So you have to look for other signs, like the friable tissue or extra fluid, before panicking.
Exactly. You evaluate the odor in context.
Okay, what about redness? If I get a cut and the next day the edges turn red, I usually assume the bacteria are winning.
Again, you have to map that symptom back to the normal phases of healing. Redness, or erythema, is a completely normal, expected part of that early inflammatory phase. That redness is just vasodilation, your blood vessels opening up to deliver the cleanup crew.
So when should I worry about redness?
It's only a warning sign if it is actively expanding outward day after day, if it significantly worsens instead of improving, or if it comes with increasing pain and induration, which is when the tissue gets really hard.
That makes sense. And what about the opposite? What about the total absence of symptoms? If my wound isn't producing any pus, I can safely assume I don't have an infection, right?
That is honestly perhaps the most dangerous misconception of all. Because as we discussed earlier with laudable pus, pus is just a byproduct of a massive, healthy immune response.
Right.
But if we're looking at a diabetic patient who has poor circulation or someone who is immunocompromised, their body physically cannot send enough white blood cells to the area to even create pus.
Oh, wow. So they could have a severe deep tissue infection silently destroying their foot.
And there won't be a single drop of pus visible on the surface.
That is terrifying. But it perfectly highlights why understanding the invisible mechanics of this war is so vital. This isn't just microscopic trivia. The macro-level stakes for humanity here are massive. Our sources note that surgical site infections remain one of the most common and costly infections globally.
The burden on our healthcare system is just staggering. And demographic trends are only accelerating the problem. Think about the global explosion of diabetes. The complication that most often drives a diabetic patient toward an amputation isn't just their blood sugar levels. It is almost always a stealthy, biofilm-driven infection that takes root in a foot ulcer.
And then you add our rapidly aging population to that. We are seeing an absolute epidemic of chronic wounds, like pressure injuries in long-term care facilities.
And those facilities are environments where biofilms just thrive and where systemic antibiotics are historically overused, which creates the perfect breeding ground for superbugs like MRSA.
It really is just this continuous, escalating arms race. We started with Semmelweis realizing he needed chlorinated lime to wash away invisible particles. Then Lister used carbolic acid. Then Fleming gave us penicillin. And now we're physically scraping away polysaccharide fortresses to fight MRSA.
The battlefields and the weapons keep evolving, but it really is the exact same invisible war.
So to kind of synthesize this deep dive for everyone, we've learned that a wound isn't simply infected or not infected. It operates on this whole spectrum where bacteria are always present.
Right.
We've seen how classical signs of infection fail us in modern chronic wounds, forcing us to look for those subtle clues like friable tissue, We've explored the tragic friendly fire of our immune system's MMP enzymes chewing up our own fresh collagen. And we've broken down the reality of biofilms, these concrete bunkers that render oral antibiotics basically useless, meaning we have to rely on physical debridement.
It really completely reframes how you view a simple scrape, doesn't it?
It absolutely does. But before we wrap up, we always like to leave you with a final provocative thought, something to sort of mull over on your own that builds on what we've unpacked today.
Yeah, so if we think about that 160-year arms race we just talked about, our primary strategy has basically always been to invent a stronger, more toxic chemical weapon to kill the bugs.
Right, a better poison.
Exactly. But bacteria in biofilms survive by hunkering down in their sugary matrices, lowering their metabolism, and just waiting out our drugs. So perhaps the future of wound care isn't about finding a better poison at all. Bacteria in a biofilm actually use complex chemical signals to talk to each other, to coordinate building that shield.
Oh, interesting.
So what if the next great leap in medicine is figuring out how to hack their internal communication networks? What if, instead of bombing the bunker, we broadcast a false signal that tricks the bacteria into dismantling their own shields from the inside out?
Hacking their communication to make them drop the fortress walls for us, I mean, that is
Mhm.
a brilliant paradigm shift and honestly a perfect place to leave it. So next time you get a paper cut or scrape your knee, we hope you take a moment to appreciate the incredibly complex microscopic battle, the perfectly orchestrated construction site, and the invisible invaders trying to hijack it happening right there under your skin. Thank you for joining us on this deep dive into the source material. Stay curious, and we'll catch you next time.